Good morning, ladies and gentlemen. So I'll be talking to you about the health impacts of household air pollution. So I'll be focusing mainly on child health outcomes. So the work that we've been doing in Kintampo over the past decade or so. All right, so this is going to be the outline. So I'll give a brief overview of the burden of disease associated with household air pollution. And then I'll talk about the life course framework on which our child health studies are predicated on. And then I'll talk about the graphs, the Ghana randomized air pollution and health study, the design and the results from the graphs. And then the follow-up, the prospective follow-up study from the graphs cohort. So, household air pollution in Ghana, as in many sub-Saharan African settings, a significant proportion of the population still use solid fuels, so biomass fuels, so things like wood and charcoal, and even animal dung for cooking and heating purposes. And in Ghana, that figure is around 70% of the population, but this approaches 90% in the rural areas. And we've talked about the health effects, right, the human health costs. So household air pollution has been associated with diseases such as acute lower respiratory infections in children, cardiovascular disease, chronic obstructive pulmonary disease in adults, as well as lung cancer. And there are effects on deforestation and forest degradation, climate change, which we heard from earlier speakers. But then also there's also the issue of poverty and gender inequality, because so cooking is in many low and middle income country settings is the role of women and children, right, in the household. And women and children have to go out there, look for firewood to collect. They spend significant amount of their time to collect these firewoods. So time that they could have used in productive ventures, times that children could have used in studying in school or doing their homework, are all spent collecting firewood for cooking. So if we look at the use of polluting fuels and we compare our region, sub-Saharan Africa, to comparable world regions like Central Asia and Southern Asia and Eastern and Southeastern Asia. So in these world regions, the use of polluting fuels over the past 40 years or so, over the past 30 years, but also projected into the future up to 2030. So the use is decreasing, right, in these comparable world regions, but in sub-Saharan Africa, it's increasing. And this is because of population growth. So population growth is outstripping access to clean cooking fuels. So if we look at the health impact, it's not all doom and gloom. The deaths from household air pollution is decreasing over the years. But then the decrease is not equal across these comparable regions. So we always compare ourselves with the Asian regions as well. So for sub-Saharan Africa, the decline is much slower. And even the region of Southeast Asia, which had much higher death rates than us, now has a lower death rate, and this trend is set to continue. So for our studies, our child studies in Kintampo, so we are using the life course model, and this is because so one's risk of disease does not only depend on contemporary exposures, right? So, if you think about these chronic diseases, cardiovascular disease, chronic respiratory disease, so your risk doesn't only increase with exposures from today or from yesterday or from a week ago, right? But it's also a function of accumulated historical exposures, especially during critical periods of development. So the life course model provides a theoretical framework for us to study how early life exposures might influence adult disease risk. And this is predicated on the developmental origins of health and disease theory. So this is basically a theory that says that early life exposures or exposures during early developmental phases can influence physiology and metabolism of developing organ systems in ways that will increase disease risk later in life. And this is linked to the critical period or critical window or sensitive window. So this is the time period during which there's rapid changes in the organization of organ systems towards increasing complexity, greater adaptivity, and more efficient functioning. And so during this period, organ systems are more plastic. So that is to say that they are more responsive to changes, and these changes can be favorable or unfavorable, depending on whether you have an adverse exposure or you have an intervention. So the concept of induction period and then also latency period in terms of these chronic non-communicable diseases. So induction period is the time between exposure and the initiation of a disease. Okay, so for these non-communicable diseases, they have long induction and latency period. So latency period is the period between disease initiation and detection. And this is a function of the disease itself, but also the ability of the healthcare system to detect these diseases. Right? So for these diseases that have long induction period, you might have the exposure early in life, but then its effects will manifest later in life. So if we consider the graph to the right, so we see here that if you intervene in the prenatal period or in early childhood period, then there's the potential that you will have the maximum health benefits, right? Because this is the period where organ systems are plastic, or this is the critical developmental period. If you intervene in the childhood and adolescent period, so you still see some benefit and reduce disease risk, but not as much as you would see in the early childhood and the prenatal period. And if you wait until adulthood, you might have just a very little window in which to prevent disease risks from establishing. So in terms of air pollution, there's growing evidence that prenatal and early childhood exposures program lifestyle, cardiovascular, and respiratory disease risk. So I'll use lung function to illustrate this concept. So lung function after birth increases rapidly. And it's good. It's a good thing for lung function to increase, right? So it increases rapidly until the early adulthood, so around early to mid 20s. So it reaches a peak around that period, and then there's an age-related decline. So this is normal. This is physiological. So after this peak, there's an age-related decline in lung function. But across the life course, there are things, experiences, and exposures that can happen to cause abnormal growth in lung function and also to cause accelerated decline in lung function. So there's the concept of maximally attainable lung function. And maximally attainable lung function itself is a risk factor for chronic respiratory disease. So if you are exposed to environmental exposures or some other exposures and you do not attain your maximal lung function by early adulthood, that in itself can increase your risk of having chronic respiratory disease later in life. So the red triangle here shows the critical period for interception of abnormal lung function growth. So if you intervene, the earlier you intervene, the better. You can get people back onto track, onto a healthy trajectory. And then the blue triangle here shows a critical period for interception of accelerated lung function decline. So there's also a window there to try to arrest accelerated lung function decline. So the lung function, the Ghana randomized air pollution and health study, the graphs. So this was a community level randomized controlled cook stove intervention trial. So this was designed to quantify the effects of household air pollution on the primary outcomes of birth weight and incident pneumonia in the first year of life. So we had 3 arms. We had 2 intervention arms compared to a control arm. So the interventions included an improved biomass stove arm called the BioLite home stove. So this stove supposedly reduces emissions from biomass fuel, from solid fuel, so you can still use it with wood, but then it burns more efficiently. So it has a thermoelectric powered fan that blows air into the combustion chamber, and this burns biomass fuel more efficiently. And then we have the LPG arm. So we gave LPG cylinders to the women, and then we also refilled it for them monthly. So this continued. So we enrolled oops, what's happened to? Okay. So the women were enrolled in pregnancy prior to the 3rd trimester. So all the women were enrolled in the 1st and 2nd trimesters, and then the intervention continued until the children were 1 year or 12 months of age. So in the graphs, we screened 1,714 women, and we enrolled 1,414. So randomized into the 3 arms. We followed them up until delivery. We had about 1,306 live births out of the 1,414 randomized. And then we followed up the children until their first birthday. So this follow-up was basically follow-up for acute lower respiratory infections. So following the WHO's IMCI guidelines. So these are guidelines for the detection and diagnosis of childhood illnesses. So we conducted passive and active surveillance where field staff visited the children in their homes on a weekly basis. And then they recorded symptoms and referred the children to the study clinic for evaluation for pneumonia and other childhood illnesses. But then there was also the passive component where mothers of sick infants self-referred to the study clinic.